Welcome to The Next Human. My name's Arav, and today I'm joined by Dr. Gurpreet Dhaliwal, clinical diagnostician and professor of medicine at UCSF. Thank you so much for joining me on the podcast today, Doctor. It's wonderful to have you on.
Thank you, Rob. I appreciate the invite.
Great. So the first thing I just wanted to ask is, could you kind of just give me like a quick rundown of your life's journey, kind of? So, like where you started from and what you did, and I guess what got you to where you are today.
So I'm a physician. I'm a professor of medicine at the University of California, San Francisco, and I practice at the San Francisco VA Medical Center. So I was born and raised in Wisconsin.
Mm.
Um, I went to undergraduate at Northwestern University where I studied economics, and economics is something I still love now. It's I think a very useful lens to understand phenomenon in society, government and politics, and just the way people behave. So I
Mm.
carry that with me, but I went to medical school thereafter, also at Northwestern University for 4 years. And then I came to San Francisco as an intern, and I did my internship and residency in internal medicine at UCSF, and I've stayed on the faculty ever since. And my main job, there's lots of different types or phenotypes of doctors that you can inhabit in the university. And I'm a clinician educator, which means I spend a lot of my time taking care of my patients. And very often I have students or residents with me. So I'm teaching them how to do that patient care at the same time.
Awesome. And yeah, I mean, so I guess just kind of what I mean, have you always been interested in medicine? Has it always been a thing for
Yeah,
you?
I think so. It's one of these things in retrospect, it's very hard for people to accurately tell their origin story. The brain is very good at retrospectively explaining and sometimes even fabricating things. I think though, I was always drawn to science. My parents are physicians, so I saw, and they're physicians who love their job. I think those things probably appealed to me. But I think I also got drawn into sort of the intellectual exercise of what a doctor does, and is able to apply that working with people. I think those elements became increasingly interesting over time.
Hmm. And yeah, so like more on your work as like a clinical educator. So like um I guess with uh teaching students or I mean medical students and residents kind of like things like diagnostic reasoning or clinical problem solving. I guess just like how do you find it like how do you basically impart these like skills and techniques to students?
Yeah, and again, at the university, different professors and teachers focus on different things. I tend to focus on their ability to reason. And usually that means making a judgment about what the diagnosis that a patient has, or making a judgment about what the best treatment is for the patient to have. And it involves a lot of skills. It has everything from knowledge to statistics to philosophy about good medical care. All of those things are embedded in it. But sometimes if I just focus on sort of what it means to make a diagnosis, it's really sort of a categorization task. So a patient comes into the doctor and there's a broad spectrum of symptoms that people can have: rashes, a joint that hurts, a lab abnormality, difficulty with vision.
Mhm.
And whatever it is, the job of the doctor is to take that symptom or problem or abnormality and transform it into a medical diagnosis, because that's our pathway then to picking the right treatments for it. So I like to walk them through that categorization task. Like
Mhm.
if someone's joint is swollen, what are the different categories of diseases that might be responsible for that? And then what is the test that we have to do to prove or disprove hypotheses? And then how do you construct an argument? So if you've taken classes in like rhetoric or debate or logic, it has
Mhm.
a lot of analogy with that, essentially sort of making your case or showing your work.
Okay. So I guess would you say like if you boil it down to just kind of its essential components, obviously like diagnosis is a lot more complicated, but it's basically just kind of like a big tree of logic gates, and it's just kind of like this yes, no, kind of like that.
Yeah, did you use the word logic gates, or yeah, the branch
Yeah.
points? Yeah, it very much can be modeled that way. A lot of times it's not a linear algorithm, or it's not a straightforward algorithm, but you're absolutely right. There are nodes that you have to make judgments on and say yes,
Mhm.
no, or maybe, and you might have to carry the maybe forward
Mhm.
with you.
Yeah. Um, and yeah, I mean, I guess I'm sorry for putting you on the spot, but I mean, could you just like give an example of like um a case and like you maybe like a challenging diagnosis that you um made and maybe some like patterns you saw and just kind of I guess you just like walk me through like how um you'd use like clinical reasoning and just yeah.
Yeah, and maybe instead of sort of something rare or super challenging, I mean, it's easier to focus on the common things that come in, because some of the greatest challenges are actually the common problems that come in. So if you watch a TV show like House MD or something, you might get the idea that like being great at diagnosis is being able to pick up rare things, kind of like in a Sherlock Holmes-like manner. But real excellence in diagnosis is the opposite. It's actually the ability to discriminate between common things that oftentimes look like each other. So I'll just give you an example. Many patients come in who are short of breath, and we do x-rays, and the x-rays show patches in the lungs.
Hmm.
And we spend a huge amount of time trying to figure out, is this fluid in the lungs from the heart that's called congestive heart failure, or is this a pneumonia, which is an infection in the lungs? They're both very, very common diseases. We both see them a lot, and yet the real skill is discriminating between the two of them. So someone who's great at diagnosis doesn't get it right 100% of the time. It's very hard to do. It's more the difference between one doctor might get that distinction right 70% of the time, and with a lot of study and logic and reasoning, another doctor might get it right 85% of the time.
Hmm.
Something like that. And what you see in there is that there's an effort to make that gradient. It's not some natural gift. There's some effort you can do, and perfection is very hard in those situations. We don't get to 100%.
Hmm. Of course. Are there like some common I guess like cognitive biases or pitfalls that just kind of like a lot of clinicians will like fall into, or just kind of um I guess some really common like patterns of mistakes that is like pretty clear.
Yeah, I mean the it's well documented, but the same mistakes that doctors do, all humans do. So this it's simply a replication of all the human fallibilities our mind has, and they just show up in the medical setting. So there are concepts like premature closure. That means like when I'm trying to make a judgment, I close the case too early
Yeah.
on.
Hmm.
Or the availability heuristic, which is just the concept that the brain is not very good at doing a probability estimate. It's much better at grabbing a salient recent example.
Hmm.
So if someone had an infection last week and it was a really dramatic case or I missed it, then I will overjudge the likelihood that another person who comes in similarly has an infection.
Hmm.
Um, or there's concepts like confirmation bias, which you hear all about in the news now, where the brain preforms an opinion and then it tries to find confirming evidence without really giving adequate space to the competing hypotheses. So
Hmm.
all of those things happen. For a period of time, we made it sort of a great insight, like doctors do this too. But then that sort of run its course, and people said like, okay, doctors do this too, but so what? Like, what can be done about it?
Hmm. So yeah, I mean, I guess now I'll pose a question like what can be done about it, and what I guess is being done about it, since like doctors play such an important role.
Yeah, in terms of, essentially is asking the question about like error reduction.
Mhm.
People look at it in a lot of different ways. Some people say like you have one tool, which is the human brain. So are there steps that you can do to improve the human brain? Some people say maybe there's a way to counteract those biases. That has been very difficult to prove. An alternative stance is essentially to build your knowledge structures better so you don't fall susceptible to those biases. So this relates to ways to how you organize knowledge, how you study, how you get feedback. Essentially, both of them are two different ways to say, I'll make my brain a better judgment. Other people have said, listen, you can't rely on the human brain, or we're getting to the limits of what the human brain can do, and you have to improve the system that doctors work in. So this might be something like perhaps you have a second opinion going on, or that doctors seek the input of the people around them, like not just doctors, but nurses and therapists and pharmacists. So you sort of do a team diagnosis. And
Mhm.
then the third, which is increasingly popular in the modern era, is like if we've reached the limits of what the brain can do, or at least a brain in this system, why not bring tech in and see if tech can augment the human brain? And so
Mhm.
there's proponents. All those are attractive. Probably all three of them are valid, and they have a different place for each one of them.
Yeah. Um, yeah, actually, I just want to like ask you to elaborate on a couple of those. So like you mentioned knowledge, or I guess restructuring our knowledge, or our knowledge system. I was curious what exactly you mean by that, and how I guess how someone can do that.
So when you have like you learn a subject like how the kidney fails or how the body develops anemia or what are causes of a fever, right?
Mhm.
Those can be organized in your mind. You can have a long list or even just a more scatter plot of answers or solutions, and you can draw on them and be right a lot of the time. But that's not the same as I have a structured way of thinking through it. So analogy would be, and if you do have a structured way of thinking through it, it actually lowers your cognitive load. Every time the kidney doesn't work in this way, I think through it very systematically. We call that a schema. And that goes for everything in our life. You can either be haphazard in trying to grab solutions, or you can have a systematic way to go through them, almost like a checklist, but not quite there. So the analogy would be like if you and I were in this podcast now and all of a sudden your internet dropped out.
Mhm.
You could be like, well, I know a couple things. I'll plug my modem in and out and I'll reboot my computer and maybe I'll log on and off Wi-Fi and see what happens. And you might get that. It might work. Or you can say, I over study and feedback and practice, I've actually developed a very orderly way to figure out how the internet's not working. Like I check with the provider, then I check the socket in the wall, then I go to the modem, then the router, then the computer, et cetera.
Mhm.
And it would assure that your mind was open to all the possibilities and that you might reveal every time you go through that process a gap in your knowledge that you improve for the next time.
Mhm. Interesting.
But
Um,
that second one's much more effortful, right? It's much easier just to be like, I go through life and my internet goes down a couple different ways. And so I picked up some tips and tricks that work most of the time, versus like I'm going to study and have a routine so that I approach it the same way every time.
yeah, and um, I think that the second, second round you're talking about requires like active relearning and just every um I guess every iteration, every like diagnosis, you're constantly um each one is active and each one requires the certain level of input or sorry or energy. And
Effort,
I
yeah.
guess um
And most humans don't do that. That's totally natural. It's not a critique. Humans are what's been called in psychology, we're cognitive misers. We
mhm,
we try to expend the least cognitive energy possible so that we preserve it for some other pursuit. But if you did want to get better, whether it's my job figuring out why kidneys don't work, or the job I posed to you of like figuring out why the internet doesn't work, it would take a lot of extra effort. You'd have to like pull out a piece of paper and draw a diagram of how the internet flows from the wall socket to your computer, right? You'd have to perhaps say, well, I should do some simulations. I should run myself through different case studies of the internet not working or a kidney not working. When I get that learning, what's a way I'm going to make sure it stays in long-term memory and doesn't fall out of short-term memory? I'm going to call someone or write it down or put it in a notebook.
mhm.
And to your point, every one of them is effortful. But those are the ways you do a cognitive upgrades. I mean, we sort of learned that when we learned to study over the course of school, but then you start to learn there's some study habits that are more effective for keeping things in long-term memory.
Yeah. And I think it's interesting because um we're kind of talking about building two different kinds of habits, and one are like the ones I guess that come almost natural to us, just kind of taking shortcuts to get, to where we are because um most of the time I guess those
It
shortcuts will,
works, yeah.
yeah, get us there. But especially in a field like diagnosis where each case is so important, um it's it's not like guess it's not a good idea to fall into these like um shortcuts, I guess.
Yeah,
And
I think that like you said is really well. They work most of the time, but your patients deserve our best performance. It's still not 100% performance, but these are efforts to get us to a more accurate rate.
hmm, awesome. And I think like I guess it I guess it means that like, diagnosticians have to approach each case with the sense of almost like curiosity and just kind of like always be sort of on the hunt for what's new or what's different. And because each I mean personalized medicine is on the rise right now. Everyone is kind of talking about, and I think like it's just that much more important that each patient gets the care that they deserve. And um that sort of means that your physician has to be like paying attention to like every detail. And I think that also ties into the thing you were talking about earlier, about data analysis and how um, that's being looked at as a venue to sort of offload some of the work or the extensive work that is required in the field. And I think so I just, yeah, I wanted to ask, like, what are your thoughts on that? Like, is that um yeah, just what are your thoughts?
Yeah, I mean, I think you're asking like, can computers assist, as it were? And I think the answer is yes. They already are.
Mhm.
Sometimes people get scared if you attach a word like AI, artificial intelligence to it, or decision support. But these are natural responses people have to technological innovations. They always will say like, the mind cannot be replaced, or this is not what the profession is. But what happens is the scope of the profession gets redefined, and not necessarily in a bad way. I mean, if the computer starts doing rote computational work, and that frees up more time for me to talk to the patient, answer their questions, and explain things. That's, many of us would view that as a net positive.
Mhm.
Um, and there are elements of artificial intelligence in our work all around us. Our EKG machines give us readouts, even though we're tasked with interpreting them. The X-ray machines now are, or the X-rays are being scanned for a finding like a pneumothorax, which is a collapse of the lung, or a fracture. Those are things that a trained radiologist does, as well as other doctors, but there's no reason you can't get an assist from the computer.
Mhm.
Remember before I said one of the ways to do it is to do a second opinion, but why not have a second opinion from a computer that's trained on millions of cases, that doesn't get fatigued, doesn't get cranky, is available 24/7? Like who wouldn't want a second opinion from a colleague like that?
Yeah. Um, yeah, I think, yeah, that's definitely um yeah, absolutely right. And I think yeah, well, you mentioned like this, this would also free up time for doctors to like you know, have the talk more with patients and explain to them. And I guess like um how important, like you're talking about like the importance of the human connection with patients. And I think like how would you say that, building a relationship with patients will kind of augments the diagnostic process?
I think, and I should say, it's my hope when AI comes on the scene that we do get more time with patients. We're not talking about this today, but there is a corporatization of medicine that has actually almost always found that whenever there's a way to eat productivity out of the system, the time with patients gets shortened and shortened. My hope is that that doesn't happen with this. But
Mm.
to your point about, um, does that spending time with patients yield the diagnostic yields? It absolutely does. I mean, I think it either just the amount of time that it takes to know the person, so you know what matters to them, only comes out through conversations. A lot of times critical diagnostic information, literally a medicine they're taking, something that happened to them years ago in the military,
Mm.
an exposure at work, only comes out because you had 5 more minutes to talk to the patient. And just in the course of things, someone's short of breath and they say, "Oh yeah, I work in a mine, and we ran out of protective gear a week ago, or a month ago." And you say, "Oh my goodness, if we had been cut short 2 minutes, I wouldn't have gotten to asking you about that." But that's the answer to this mystery.
Mm.
That sort of, or someone's having trouble breathing, and then you're like, "Boy, I don't know what it is," and then you learn that they have a parakeet, which sometimes can cause a reaction in the lungs called hypersensitivity pneumonitis. All of those things come out through conversation. And a lot of it is serendipity. It's really good luck, but that good luck only comes through time. Uh, And that's becoming increasingly harder in modern healthcare.
Mhm.
So anything that would give us more time with patients, we would appreciate.
Yeah. Um, yeah, and I just wanted to ask, like, obviously from like talking with you and I mean, just from looking at your work, I mean, I'm sure you are yeah, in love with the field. And I think it's like it's kind of a silly question, but I mean, do you think that love is kind of necessary for your clinician to have?
But no, it's interesting. I love being a doctor. I mean, it's hard for me to overstate that concept.
Mhm.
Like I still, there's a phrase like, if you love your job, you never work a day in your life. And that's what I feel like. Like this is just the combination of things I have with patients and trainees, and working in a VA hospital, being in a university setting. All those things make this absolute treat to me. I
Mhm.
don't think it'd be too much to say like people need to have, I think you asked passion, was it? Or I forget what the word was.
I think love or something. Yeah. Just
Yeah,
like
or sort of deep
passion.
love for your profession, etc. I think people can do a very good and perhaps even excellent job without having deep passion for it. it's hard to do things that are perhaps ingenious or push the field forward, or are innovative, because oftentimes those things take an extra effort, and it's hard to sustain extra effort without true affection or interest for a field.
Mhm.
Um, I think it's just upside. I don't think we want to hold everyone to the bar of saying they love their job to do a great job of it. But it's certainly, when that happens, I think it's the best circumstances for you to be your very best.
Mhm.
Whether it is like, being a doctor, being a teacher, or being a researcher or a leader, those are all big roles that happen in medicine. And loving that thing makes it much easier, much more enjoyable to do it.
Right. Yeah, and I think well, we'll see what I end up doing, but I think hopefully will end up doing something I love. So
Yeah, that is the goal. And I think you can also, I mean, I think it's probably true of anything in life, which is you can learn to love it. Like, that people are put in all sorts of circumstances in life, the people they're with, the places they live, the jobs that they have. And some of those external things have objective traits that make it easy or hard to like something. But there's also people's capacity to see the good in what they have, right? I mean, it's very possible to have someone who has my exact circumstances in this job and not like it. It's not a fit for them, or maybe they don't have a predisposition to it. But
mhm.
um, it's hard for me to separate how much it's I like it versus it's like me, and the synergy is there.
Yeah, I mean, so I guess just as we're wrapping up, I just want to ask like how I guess like how do you personally stay I guess engage is the wrong word, but I guess just how do you keep honing your, diagnostic skills, and are there like certain practices or just again like that like little like checklist like router modem this, or is it just like are there like techniques or something that you yourself practice and that you teach your students?
Yeah, I can share a few techniques that I use. I think the foundation is, as I'm in, many years into my career, I still see a lot of patients. That's one of my foundations. It's like I'm an athlete or a musician or someone, like you have to keep doing the thing every day in order to trying to get better at it. So I do that. I have the good fortune of doing it in multiple settings. I
Mm,
work in the emergency room. I work in the hospital. I work in the clinic. You might, if you want to use the athlete analogy, that's like cross training. So I see people and patients and diseases and treatments from different perspectives. Those settings are all very different.
mm,
I do some things myself to sort of update my mental models in my brain. So I track a lot of my patients that I see. So in the emergency room or the hospital, I may see people for a short period of time, but I have a system of tracking them. So I find how the story ends. Like the brain
mm,
can't really form a mental model unless it knows how the story ends. Um, I like to read extra cases. So there are fields where people try to become better by working in simulators. That could be a chess player who plays online chess, or it could be a pilot who gets into a multi-million-dollar simulator. But the
mm,
point is, like, you're trying to give your brain more reps around challenging cases. So I read a lot of cases, and some of them are long form cases that take like 40 minutes to read, and some of them are an app that shows up on my phone every day, and it's just a 5 minute like quick hit. But essentially trying to put more cases in front of me. And then I would be remiss if I actually don't state that probably the biggest thing is that I teach and I'm in a teaching environment, because when you have to teach, then you really have to understand something. A lot of
mm,
times I find myself sort of practicing on maybe in a reflexive mode or using familiar things, but when I have to explain it to someone else, back to that internet analogy, I would
mm,
really have to know my stuff. I would have to make sure I know the difference in a modem and a router, and what are the techniques to figure out which one of those things are wrong, and how frequently it happens, and what does the literature say. And that's all forced upon me. And I mean that the best way possible, because I'm a teacher, because I have to explain it, and I'm around smart people who ask me those questions. So those are probably some of the things that help me reduce my error rate or increase my success rate, whichever way you want to describe it. And I'm very grateful for all of them.
yeah, wow. And I think I think it's amazing that you um do all that and you're still like um so in love with the field. And I guess so we're almost running out of time, so I'll just throw out my last question here, which is just what is, like one piece of advice you'd give to high schoolers, college students, med students, residents, or just anyone really who just wants to kind of pursue a career in um, like clinical work or clinician educators or diagnostics. So yeah.
I mean, there's so many great pieces of advice. It's hard to pick one thing. I think maybe one thing I lean on is counterintuitive, given how much we've been talking about sort of technical and cognitive things, which is no matter what you are in, almost every field's joy comes from interpersonal interaction. It's certainly the case being a doctor. And so sometimes we focus on being smart. I mean, you and I talked a lot about actually how you update your mental models, how you become smarter. We try to get the right grades, the right test scores, all the things to become this. But in the end, what you realize as a piece of advice I got a long time ago, which is that it's not really the smarts that distinguish you among, at least sort of not in the field of medicine, because smart is a dime a dozen. Tons of people are smart. And so one time someone told me this. He said, look around here. He said, everyone here is smart. You should distinguish yourself by being kind. And really sort of emphasizing that intellect is important, but if you really want to enjoy this field and deliver on its promise to patients and society, you have to be a humanist first. And so I always am working on both parts of that equation.
Um, wow. Yeah, I think um that's yeah, I mean that's essential. I think I don't know why I've never heard that before. Because it just seems something so basic and so essential. So thank you, I mean, for that advice. And again, thank you for joining me on the podcast today. It's absolutely like wonderful to have you on.
Marvelous. Well, I really enjoyed our conversation. I'm glad. I appreciate you inviting me, and the questions you asked really got me thinking. So thank you.
Great. Well, I'm glad. So yeah, thank you so much. I think I learned a lot today.
All right. Bye, Rob. Thank you so much.
Yep. Have a good evening.
Bye-bye.